Good morning, everyone. This is Kelsey Berkfeld, Director of Advocates for Ohio's Future, and welcome to our second installment of the 2022 Budget Training Academy. We are so happy that you're here with us this morning. We have a great program lined up for you, lots of great information, specifically from a landscape of what's happening really across health and human service issues in the state, as well as we are excited to hear from a number of folks who help guide that policy, who help inform that policy from our administrative agencies. We're excited to have them here today. I will go ahead and get us started this morning. And if we can go to the next slide, we'll kick things off. Excellent. So like I said, my name is Kelsey Berkfeld, Director of Advocates for Ohio's Future. I am joined here with my colleague, Sarah Hudasek, and we work for, again, Advocates for Ohio's Future, or AOF, as we will refer to it throughout today's presentation. We really are a coalition of health and human service organizations. We have everything from providers to researchers to policy folks, really that cross and are experts in a broad range of health and human service issues, knowing that in order to make real change for families and increase well-being and enhance our healthy communities, we want to make sure that we're all working together, recognizing all of our issues are intersectional and all must be paid attention to make real change. Again, we want to make sure that we promote health and human service budget and policy solutions so that all Ohioans live better lives. And just a brief look here at some of the issues that our coalition pays attention to that, again, all work together to ensure healthy families and communities. Excellent. And then a little bit of housekeeping here, some administration. This webinar is being recorded in full. Recording and slides will be up at the latest tomorrow morning at our website there on the screen. And then if you have questions throughout our presentation today, you are welcome to enter them in through the chat or the Q&A session. We will be breaking periodically to answer some of those questions as we move forward. Excellent. So this session was dubbed Health and Human Services 101. And we're really here to set a little bit of a stage as to all the different departments, all the different work and issues that really span health and human services at the state level in Ohio, and how different departments work together to provide vital services for folks all across the state. So very, very briefly, we will kind of overview our 6 departments, our major departments. There are certainly different commissions and such that feed in to make health and human services run in Ohio, but these are our 6 major ones that I know my organization and our partners at Center for Community Solutions work with very, very frequently. The first being the Department of Health. We have the Department of Jobs and Family Services, as well as the Department of Medicaid. Also the Department of Mental Health and Addiction Services, Aging, and then the Department of Developmental Disabilities. So once again, these are cabinet level agencies. So their directors are chosen and selected by the governor of the state. So these are not elected positions. And each of these departments work really, really closely with different stakeholder organizations, with local governments, with local maybe jobs and family services, local ADAMS boards, kind of different levels of government organizations to make sure that they are providing, again, quality programs and services across the state so that they have everyone covered. And if you are in need, if you have a health issue or a concern, that you know where to turn to find that best service that meets your needs and meets the needs of your family. So very quickly, we will highlight just a couple of the programs that are offered and run by our state level departments. Department of Health, of course, I know everyone knows a little bit more about what the Department of Health really covers from the coronavirus pandemic and all the incredible tracking work that they did during really the thick of things a few months ago, years ago at this point. But just wanted to point out a couple other functions of the Department of Health. Their food safety program, of course, incredibly important. They also lead the Infant Safe Sleep initiative, HIV prevention, Help Me Grow programs, immunizations, really just a small snapshot of some of the work that the overall State Department of Health provides throughout the state, as well as coordinating with local health departments to continue that work. Department of Jobs and Family Services, of course, really providing vital supports to folks, specifically through the pandemic, or when folks maybe have some time looking for a new job opportunity, or if they find themselves without work. This is the organization, the state program that runs unemployment, as well as food assistance, cash assistance, child support, protective services. Really, we would say, again, as you can see by their mission statement, really interested and there to support the well-being of Ohioans by strengthening families and promoting economic stability, working very, very closely with county jobs and family services offices as well, to have kind of maybe closer touches to folks. And we know that many Ohioans will probably interact with the Department of Jobs and Family Services, if not really most of our agencies that we're going to talk about today within their lifetime. The Department of Medicaid provides, again, health insurance to more than 3 million Ohioans and other vital services to ensure that folks are healthy and have the services and medications and prescriptions and supports that they need, again, to live the healthiest lives available. Of course, on top, and really that everything that's rolled into health care coverage. Some other services included, of course, health check. We want to make sure our youngsters are as healthy as possible as they begin school and grow up. We have My Care Ohio as well, maternal and infant health supports, specialized recovery services, home and community-based services. And I would say that the majority of the other organizations and other agencies that we are going to speak to today also interact with the Department of Medicaid. Many of them work together to ensure that programs are working most efficiently, that providers are there to help folks who need it, and that everything is moving and running as smoothly as possible, and the services are there again for folks when they need it. About halfway through, my friends, we are getting there. The Department of Mental Health and Addiction Services, again, making sure that high quality mental health and addiction and prevention, treatment and recovery systems are available across the state. I know working very closely as well with providers and local boards to ensure that those services are strong and available for folks when they need it. Really honing in on prevention services, again, treatment, recovery, and then making sure those providers have what they need to provide high quality services. Aging, Department of Aging, again, making sure that the needs of our older Ohioans are met and that they can live really healthy lives in their communities with care that's appropriate for them. They also run the Office of the State Long-Term Care Ombudsman. That's a tough word. The Ombudsman's Office. I know some folks will interact with them later in life, making sure that our older adults have connections and community connections so they can stay, again, in their communities, in their homes as long as possible, and also making sure that providers are there and doing what they should to make sure our older adults are receiving that quality care. And the Department of Developmental Disabilities, of course, ensuring that folks, again, across their lifespan have supportive services focusing on their health and safety, as well as making sure where appropriate, folks can be as integrated in the community as possible, making sure they have those mobility assistance, as housing, making sure that those opportunities and options are available across communities, and making sure that services and other employment training and services programs are there for our folks with developmental disabilities. And before I turn it off to our friends at Center for Community Solutions, we'll hear first from Lauren Anthus. Wanted to again point out that a lot of these organizations, a lot of these state departments work with lots of partners, with organizations and advocacy and policy organizations like Advocates for Ohio's Future, as well as Center for Community Solutions, working together to make sure we come up with the best plans and policies to advocate to our decision makers how we can, again, make sure that our policies dictate and support strong, healthy communities for folks to come. Again, lots of folks may interact with these different departments throughout their lifetime. As somebody who has been on all of their websites very, very recently, I will say a very excellent source of information, of resources, how to connect to services, to care, just really fantastic resources for folks if you are in need of any of the services that we mentioned earlier. And without any further ado, I will go ahead and turn it over to my friend Lauren Anthus, who's going to give us a little bit of perspective of the major issues really across those departments that we have been talking about, and his predictions for some of the major issues that we will be seeing and dealing with in the upcoming budget. So Lauren, when you're ready, please take it away.
Thank you, Kelsey, and welcome everyone to this Budget Academy session. We really appreciate the opportunity to meet with you today, and also want to just take a moment to thank our partners at the state level for making the time. They're in the midst of developing their budgets as we speak. So, the fact that they created some time for all of us, just wanted to say a note of thanks for that and for their partnership generally. Just a little bit of background on the Center for Community Solutions. We're a nonpartisan, nonprofit think tank based in Cleveland with offices in Columbus. And you can see our mission and our work here. Essentially what we try to do is enable organizations, social service agencies, and others by helping them understand more about what happens in public policy, particularly on the state level. If you are not familiar with us or would like to learn more about the state budget or about policy issues generally in Ohio, you can go to communitysolutions.com. We also have a very unobnoxious newsletter you can sign up for that is issued every week on Mondays, where we highlight some of these issues. And then we'll be tracking the budget and trying to explain some of what's going on throughout the process. I'm joined by my colleague here today, Natasha Chechimaica, who will kick us off to review some pieces around maternal health. If you have any questions from us, you can always, if you don't mind going back for a second, thank you. If you have any questions for us, any follow-up that's needed, always feel free to reach out to us via email. We're more than happy to make ourselves available. We sort of informally say that we're the people who help people who help people. So if you need any assistance, if you have any questions about what's happening with the state budget, or state policy generally, more than happy to connect with you. And for today, what we're going to do is we're going to talk a little bit about some of the priority areas that we had during the last budget that sort of underscore just how important the health and human service delivery system is on the state level. And Natasha will walk through some of the maternal and infant health policies that were developed in the state. Some really positive things. Just yesterday, an announcement was made that around postpartum coverage that Natasha will cover that is going to be transformational for thousands of women in our state. And then I'll go into a little bit around Medicaid. Medicaid is a big part of our state budget. So what happened over the last couple of years? How did the Medicaid program respond to the pandemic, and what happens now that we're sort of unwinding from the pandemic? So with all of that, I will pause and I'll hand over things to my colleague, Natasha.
Thank you, Lauren. Again, my name is Natasha Chechimaica, and I will talk about maternal infant health highlights from the last budget. Thank you. So one of the major things that happened from the past budget in regards to infant and maternal health is the Medicaid expansion on postpartum coverage. So as of April 1st of this year, Medicaid coverage for breastfeeding people has been extended to 1 year after they have given birth, and is for individuals up to 200% of the federal poverty level. So that pretty much means that $15 million of all funds, in which the state has a share of $4 million per fiscal year, has been allocated. And according to the American Rescue Plan Act, states can maintain this plan until March 31st, 2027. It's strongly encouraged, but not requirement. However, states who have implemented this program before, Ohio have done it, have already seen a increase in positive feedback, positive results from this extension. So if, for example, there has been an increase in postpartum care visits, enhanced engagement of people in healthcare, and continuity in coverage. So we hope that Ohio will experience the same positive results as well. Another program that have received some funding from the state budget is Help Me Grow, in particular their home visiting program. And it's a program that supports pregnant individuals and new parents who experience risk factors. The program has certain goals, which includes improving child and maternal health, prevent child abuse and neglect, encourage positive parenting, and promote child development and school readiness. They provide parental education, prenatal support, and this program has received roughly $41.2 million for each fiscal year of 2022 and 2023. And there was a rule that was implemented as well from the state budget. So they have extended the maximum age in which a child can be eligible for home visiting services from 3 to 5 years old. And lastly, I'm going to talk about infant vitality. So this program pretty much focuses on numerous initiatives provided by various departments from the state of Ohio to combat infant mortality. In fiscal year 2022, they were allocated roughly $17.6 million. Whereas in fiscal year 2023, they have received roughly $12.1 million. And the reason for the increase in funds between the 2 years are 2 programs that have been earmarked for just only fiscal year 2022. So that includes community and local faith-based service providers that invest in maternal health programs. These providers pretty much offer services and supports for pregnant individuals in order to improve health outcomes for babies and birthing parents. And then the second program is actually a universal health needs assessment. And the purpose of that assessment is to identify and offer health and wraparound supports for birthing people. The remaining of the funds for infant vitality has been allocated for different initiatives such as safe sleep, smoking cessation, gestational diabetes, but also increasing awareness of certain health issues, supporting data collection, analysis, and interpretation to impact decision-making and accountability, and also targeting where the need is the greatest. So these are some of the major things that have been highlighted and noted from the past state budget. There has been other stuff that has happened in infant maternal health as well. But if you have any questions about that, feel free to reach out to me. And if you can go to the next slide, please. I will pass it over back to Lauren, who will talk about Medicaid and the PHE.
Thanks, Natasha. So I'll just take a few minutes here to talk about Medicaid and the public health emergency. I think what's really remarkable about what Natasha just shared is just how deep the state's role is in addressing some of the most common public health challenges that we have. Ohio has a sordid history with maternal and infant health, and it's really the state apparatus that has to respond to a lot of these emergent needs. And Medicaid plays a pretty significant role in that. Often it's referred to as a first responder in public health, Medicaid. And that was certainly the case as we have been grappling through the pandemic over the last couple of years. And just looking at what we're talking about here, if you look at caseload, so the number of people who are enrolled in the program, we saw some pretty significant growth. And this is because alongside the pandemic, we also had an economic recession where people may have lost their job or may lost their employer-sponsored insurance. And so Medicaid played an important role in ensuring that people had access to coverage, most notably for children and parents, working adults, folks who otherwise would have not had coverage if not for the Medicaid program. And Medicaid at this point, covers about 1 in 4 Ohioans, and currently is about, I believe, 4% of our overall gross domestic product in our state. So when you're thinking about the economic well-being of our state, when you're thinking about the continuity of care needs that many people have, Medicaid plays a really important role. And you can see here that just between January of 20 and January 22, just how significant that role was. Next slide, please. Now, with the last budget, one thing to pay attention to was around how the General Assembly made some requirements regarding eligibility. The last budget was known as House Bill 110, and it essentially said a few things. First, that the department must complete eligibility renewals and determinations within 90 days of the termination of the PHE. I think that there are some questions between the state and federal governments about how that may actually play out and what that's going to look like. But this also included within 60 days, complete and act on eligibility redeterminations for all beneficiaries who had a redetermination in the last 12 months. That ODM also must seek approval from the Centers for Medicare and Medicaid Services to conduct redeterminations for all these beneficiaries, and then procure a vendor to use third-party data resources to identify individuals who are likely ineligible. Now, one thing I'd like to highlight here is that there's been a tremendous amount of work that the department has implemented, that the Department of Job and Family Services has implemented. So I want to thank our partners at both of those departments for all of the work that they have conducted over the last couple of years to prepare for this. I will say though, when you're talking about 3-some million people, it's important to pay attention to how this all works. So this is something that Community Solutions will be paying attention to pretty closely. I know Advocates for Ohio's Future has been pretty involved in these conversations, but regardless of the provisions in last budget, I believe the state is well poised to address those provisions, first of all, and make sure that they meet the mandates set forward by the General Assembly, but has also worked really hard to equip county departments of JFS and managed care organizations and providers with the information they need to ensure that people maintain a certain continuity of care. But it's something to watch, because over the last couple of years, we have not required people to go through the typical eligibility process. And even on the local level, at the county level, there may not even be caseworkers who have ever processed an eligibility determination. And they're, just like any other employer, facing staffing challenges. So it's something to pay attention to and something to watch. And obviously, this might be an area of concern in the next budget. Next slide, please. All right, so with the next budget, some things that we're going to be paying attention to specifically with Medicaid are, number one, managed care implementation. So for those of you who aren't as familiar, the main conduit through which the state manages its benefit is through managed care. We have a privatized Medicaid program in the state of Ohio. I believe, and Stephen may correct me if I'm wrong, around 95% of all enrollees in the program have a managed care plan who oversees their benefits. So with that, there has been a shift over the last several years to the DeWine administration to try to get more value out of our managed care program, and also not only get value, but make it more efficient. So there has been a significant effort to change the way that we manage managed care and contract with them. And a number of efficiencies have been identified already, but there's still a lot of work to be done. So what does that look like, and what does that mean for individuals? It will be interesting to see how this plays out, how individuals understand what this new system looks like, and how the interplay works. One of the things that I think anyone who follows Community Solutions work knows is that multi-system youth is an area that we've paid attention to for a long time. These are adolescents and kids who, might deal with multiple systems, whether that might be the juvenile justice system, Medicaid, developmental disabilities. And oftentimes it's unfortunately resulted in custody relinquishment, essentially where parents have to make some pretty hard choices when it comes to making sure their kiddos can get the services they need. We have a new managed care benefit that is being deployed as we speak, and we have, I think, nearly 8,000 kids who are already enrolled in that program. So how does that work, and how do we carry that forward, and how does that connect to our new managed care system generally? Beyond that, the termination of the public health emergency. So eligibility is going to change, right? We have this mandate to process people in this through their eligibility determinations. We've seen incomes go up and down. There's also inflation, obviously. So, with that, what's the role of Medicaid in making sure that people have access to healthcare? And then also the loss of one-time money. One thing that we noticed, or one thing that was a part of the federal response to the public health emergency, was ensuring that states had additional federal support through the Medicaid program to ensure that people had access to coverage. And this makes sense. If you have more people enrolling in the program during a health emergency, you would want them to have access to health care. And at a time when the economy restricts, Medicaid tends to spend more money because it's countercyclical. So the federal government provided some additional dollars. Those additional dollars have really stabilized our budget in a number of ways. But as we are sort of unwinding from the public health emergency, the economy picks back up, we're also going to lose those dollars. This is, I think, what Director Corcoran from the Department of Medicaid referred to as the pig and the python, this interplay between eligibility and the pig and the python. I see it just sticks with me. The interplay between eligibility and enhanced federal funding. Another thing that we'll be taking a look at that is more general to the state budget process is revenue. Right now, the state of Ohio is doing pretty well around revenue. Our economy is doing pretty good. The economy generally across the United States is pretty good. We're at near record lows for unemployment. We're seeing still a decent amount of sales tax revenue and income tax revenue. And usually when that happens, there's a question of, well, do we need to rethink our tax structure? And the question is, well, is that going to create some systemic challenges in the future? I think this is something that's already been teased out in some policy circles, so that will be something to pay attention to. In what ways is revenue or our taxes are going to change or be addressed? Again, maternal and infant health, while there's been lots of progress that's made, there's still a number of things that we're interested in. First of all, expanding the perinatal workforce. So that includes, leveraging other types of medical professionals like doulas and midwives as a part of the care delivery system, improving our women and infant children program. WIC Ohio does a good job and covers lots of people, but there's also some challenges when it comes to connecting people to those services, ensuring eligibility is there. So I know our colleague Hope Lane, who's not here today, will be producing some research in this area. And then also we're going to be looking back at LARC access. A LARC, or long-acting reversible contraception, is a known strategy for addressing infant and maternal health and infant and maternal mortality and morbidity. Obviously, the political environment has changed. So how can we make sure that there are still clinical options available for individuals who may see this as a reasonable or an important option moving forward? And then, of course, how do we think about pandemic EBT? We've seen a lot of benefit available through additional dollars going directly to families. How can we make that more permanent? And then looking at TANF. TANF has sort of been one of these programs where, depending on the budget cycle, some legislators see this as an opportunity to fund certain projects they may be interested in. And the state government also has its own imperatives in regards to how they leverage TANF appropriately to address issues of poverty and family stability. And obviously, family stability is one of those areas of policy concern that will gain prominence throughout this budget cycle, given kind of where we are politically. So we'll be paying attention to some of those choices and trying to communicate those things out as best we can. And of course, this doesn't capture everything that happens in the state budget. Kelsey very expertly and deftly went through the broad array of services that our Health and Human Service delivery system provides on the executive level. So this is just a sort of snippet of the main things we'll be paying attention to. But the good news about state budgets is they're always a little bit fun. There's always some opportunity where some things will come out that will surprise us. So whatever the need may be, whatever the policy or program may be, always feel free to reach out to us at Community Solutions or at Advocates for Ohio's Future, because we're more than happy to work with you and help you understand kind of where things are going and what resources might be available to you. So with that, I think that concludes my section, and I'll hand things back over to Kelsey so she can introduce our guests from the executive. Thank you.
Excellent. Thank you so much, Lauren. And it takes a certain kind of advocate to approach, the first word to use for the budget process is fun. I think that's a good mindset to take moving into what is certainly a fun and interesting 6-month process for sure. Well, I am also excited today and honored to be joined by such great folks from a number of our executive level agencies here, again, interested in the health and well-being of folks and communities across the state. First, we are excited to be joined by Mindy Kowalski from the Ohio Department of Jobs and Family Services. Mindy, whenever you are ready, you are welcome to kick things off. Thanks for being here.
Thanks. I am Mindy Kowalski, as she said. I am the Assistant Director over Health and Human Services for the state. And I believe what my charge was today is to tell you a little bit about the budget and where we are at HHS and where we're going. As you all know, we've received multiple ARPA funding. We are still waiting for appropriation for our discretionary ARPA funding, which is with our child care group. That is not been appropriated yet. And we are hoping to maybe get that in the budget. If not, hopefully sooner than that. So that is one thing that we are focused on. Other things that we are focused on is really workforce. We understand that there is a workforce crisis across the nation, but we know that in our childcare workforce and in our county workforce, they're really struggling. So we're focused on how we can support them and what initiatives we can to help them stabilize. That will be one thing that we focus on in the budget. Other things that we're going to be focusing on is prevention. So how do we look at prevention? I say to my team all the time that we independently but dependently affect each other. So if a family is food insecure, they are more likely to end up in my foster care system. So how do we create wraparound services for families so that we are providing them with the resources they need to be successful long term? So we are looking at how we can do that in the budget as well. Also maintaining programs. So the programs that we currently have moving, how do we continue to support them and to move those forward? We have a governor who is very child focused, and that has been a blessing because we've been able to move the ball on things that maybe we wouldn't have been able to move the ball on as quickly and as efficiently as we have. Our CST recommendations, we have all 37 in progress or finished, which is a huge accomplishment for my team, and I'm very proud of that work. So we are going to continue to move that forward. We will also be taking a look at SACWIS and making updates to that system to make sure that it is doing what it needs to do for the counties. But really the focus in this budget will be around workforce and around preventative services and how we can better support our families coming out of the pandemic. Or I guess we're not out of the pandemic, but coming post-pandemic quarantine and how we can help our children, because another focus of the governor's office is mental health. So those will really be our buckets as we move into this next budget cycle.
Excellent. Thank you so much. Mindy, I think we have one question we will answer really quickly while we have you. We have a question that came in. Why does ARPA childcare funding have to go through the state budget? Why can't the department spend it if it came from the federal government?
Great question. And this is before my time, so if I say something incorrect, please don't hold me to it. It was put into law by the legislatures, I believe about 5 or 6 years ago, that if you have a certain amount of funding that you get from the federal partners, that you have to go through the legislature to get appropriation. So we really have our hands tied on that, and we can't really do anything. But I will say, to our credit, we did get the stabilization grants funding out. So childcare programs are receiving stabilization grants. We are in phase 3 of it, and we expect to do at least 2 more phases.
Excellent. Thank you so much, Mindy. And yes, I would agree. That rule was put in place after the expansion of Medicaid a number of years ago. So you're absolutely correct. There is a fund limit, an amount where those dollars do have to be approved by the legislature rather than controlling board or another kind of body. So absolutely. Let's see, we'll maybe hit one more question. Is the childcare childcare fund the only ARPA dollars left for OEJFS to spend?
It's not. So we do have SNAP ARPA. And that is, we have 2 rounds of it. We have $11 million each year. We are coming to the first end of the first $11 million, and then we'll have another $11 million going through this next federal fiscal year. We have projects that we're working on that we're going to continue. Some of those projects are notice redesign. We know that our notices can be complicated and burdensome to our clients. And so we're really we're doing a human-centered design approach on it to get those moving. We're looking at our self-service portal. Why aren't people utilizing it? We know that if we got more people to the self-service portal, it would open up resources for our county. So we really need to figure out how to drive more people to the self-service portal. If it is that it is not user-friendly, then we need to work on that. So we are moving things, a SNAP ARPA around things that we can do. We are also looking at how we can get the county some funding from the SNAP ARPA as well. But yes, we do have SNAP ARPA to spend.
Excellent. Maybe one more question, then we will move on to our next presenter. And then any other questions, I believe they kind of cross departments here, so we will save those for the end. So Mindy, how does Ohio's county administered system impact what your department at the state level asks for in the budget?
So we work very closely with our county partners and their association to determine what their needs are. Most of our counties are quad combined, which means they are a combination of Medicaid, child welfare, child care, and SNAP TANF. And so we really work closely with them to figure out what their needs are. We are constantly trying to figure out how we can help them, how we can make things more efficient. And some of it we're tied for, right? So as far as workforce, I can give you some tools, but I can't hire your team or those kind of things. So we really try to hear the counties and hear what their needs are and be reactive and supportive of them.
Excellent, Mindy. Well, we appreciate what you could share with us today. And if you wouldn't mind staying till the end, I think we have a couple questions that may, again, cross departments that we will save to the very end. With that being said, would like to invite Vanessa McMahon from the Ohio Department of Mental Health and Addiction Services with us today. Vanessa, thank you for your time. Whenever you're ready, please go ahead.
Yeah, thank you for inviting me. As Kelsey said, I'm Vanessa McMahon with the Ohio Department of Mental Health and Addiction Services. So I'm sure many of you saw, but in Governor DeWine's State of the State speech, he really talked about the importance of building a full continuum of care. And if you could go to the next slide, please, that would be great. Thank you. And he, building the full continuum of care to support people who are struggling with mental health and substance use disorders. And so he said, if we build on our successes and the work we have started together, we can truly bring about lasting change. The system isn't broken. It was just never fully built. And so it does not exist everywhere in Ohio yet. And so we must build it. So we were very thankful and excited to see that his focus and placing a priority on building this system. Next slide, please. So for the upcoming budget, OMAS is focusing on building on today's successes for generational change. And part of that includes fully developing Ohio's crisis system, making prevention, treatment, and recovery services more available, growing early identification and intervention, and expanding community behavioral health capacity. So on the next slide, we put out a little graphic just to kind of help guide and inform what we're doing with our priorities for the budget, because supporting healthy people in the community happens when you expand Ohio's continuum of care. So we have the goals to grow community capacity and also sustain that capacity. And so as part of growing that capacity, we are focusing on prevention, housing, employment, day services, outpatient treatment, short-term residential, and step-down centers to reduce hospital stays. And then as far as sustaining, this part of sustaining the system is making sure that people have access to acute inpatient clinical care for when they need those services, that they not only have access to it, but they know how to access those services and where to go when they or their loved ones are struggling. And, underlying that tenet, though, is workforce recruitment and retention. Ohioans will benefit from expanded community-based outpatient treatment and supports, added housing options, more residential treatment options, and increased capacity for crisis response. Investments in these areas allow for care, treatment, and recovery to occur at home and in the community instead of institutions, so that people can live, work, and play within their communities. And on the next slide, we kind of talk about Ohio's behavioral health workforce. We through some data that we've collected and studies that we've been reviewing, we've learned that nearly 2.4 million Ohioans live in a community that does not have enough behavioral health professionals. We know that demand for behavioral health services has increased over 300% from 2013 to 2019, while the workforce only increased 174%. And so we know that we need a strong behavioral health care workforce that supports the health and well-being of Ohioans in our state. So workforce is one of the top priorities of the department. And through those priorities, we are working on increasing career awareness, educating Ohioans on the people, professions, and pathways leading to a successful career in the behavioral health field, and educating students, high school students, making them aware of the opportunities available to them, supporting recruitment. We want to be able to offer Ohioans interested in behavioral health careers scholarships, stipends, and paid internships tied to post-education service in the behavioral health field, especially in the underserved, high-need areas in those community behavioral health centers. And we want to incentivize retention. We want to support Ohio's educators and their abilities to develop an increased capacity for advanced degrees, credentials, and distance learning opportunities, and then support employers in their abilities to offer retention bonuses and offer continuing education and training opportunities. We often hear from providers that they struggle to maintain a behavioral health care workforce because their employees can often go somewhere else and make more money doing something different, or they can go somewhere else and be recruited with retention bonuses. And so we want to be able to help providers with that and help them be able to retain the workforce that they have, and support contemporary practice, expand support of the workforce with best practice development and training. And, at the center of this work is Ohioans. It's important that we keep their faces and voices in front of us as we walk down this path. This means listening to the needs of Ohioans and acting with urgency to provide a continuum of care that delivers healing and hope and focuses on the dignity and worth of each person we serve. And delivering that continuum of care requires full and equitable engagement of hundreds of organizations and relies on all of our combined experiences to strengthen the foundation of our system, which is why I'm so, grateful to have been invited here today to provide this information, because, hearing the perspective from all of you is really something that we want to hear and want to understand and use that to help inform all of our work. And then just to kind of further wrap around what the governor said, he said, we must do the work that has never been done. We can create the opportunity for people with mental illness or addiction to build the skills to lead joyful, meaningful lives. And if we do, it will result in reduced community costs, more people working, more people contributing to the vitality of their communities. And I also included on the last slide, there's the OMOS budget contact. So feel free to reach out to us at any time. We'd be happy to hear your thoughts.
Excellent, Vanessa. Thank you so much for your overview. I know I learned a lot during that time. So let me take a brief look at the question and answers. So one question for you, could you share briefly a little bit about the $85 million investment the DeWine administration announced in May using ARPA dollars to grow Ohio's behavioral health workforce? Has that money been appropriated, and has it been determined how local communities will receive those dollars?
Yes. So the money has not been appropriated yet by the legislature. We have been having meetings and conversations with both the House and the Senate over the summer. We've had a lot of good feedback from them. And so we are still working in partnership with them. And, we do need legislative approval, and we have shared with them that we are open to their guidance and however they would like to move forward with that, whether that would be through legislation or the controlling board. And so we are having good conversations as far as getting that money out into the communities. So we are working also with the Department of Higher Education for this funds, because we know that a a certain portion of the funding is planned to go out through the colleges and universities so that they can give a portion of the funding to students that are in their last 2 years of their, whether, it's a college or a university, but in their last 2 years of their program, and be able to send it out that way for paid internships, for maybe help with paying for licensure costs or exam fees, any of those things. And then also there's a portion of it that we plan to distribute through providers so that they can offer recruitment and retention bonuses to those students who will want to work with them or work at their community behavioral health center after they graduate.
Fantastic. One last question here with you, Vanessa, and then I believe we have a couple that we'll ask you about at the end as well.
Sure.
So what are some current strategies to increase awareness and acknowledgement around the new 988 line?
So the new 988 line, so we have, and I can send the link. I don't know if Kelsey, if you want me to send the link to our webpage to you to distribute out, or I could throw it in the chat, however you prefer. But we do have, a page on our website that talks about 988 implementation. And so we have a lot of information and resources there. As far as a full-on marketing strategy, we have to wait for guidance for the federal government. They are driving this because it is a nationwide policy. And so what they viewed July 16th, when 988 went live, they wanted that to be a soft launch. Where we took a couple months, where the SAMHSA and the states all the states took a couple months to work out the kinks, make sure the system's working, and then do more of a strategic marketing plan to make people aware of it. And the local numbers that are already available, that already have been available, are still there. We didn't want to take out a safety net before we knew that 988 was working, and they're still there. They will still remain being there. But as far as the bigger marketing strategy, we don't have that information yet, but I will send you the link to our webpage where we have put a lot of stuff on there, a lot of information. There's a graphic on there that talks about when to call 988 versus when to call 911. And for what it's worth, we almost had a booth at the state fair, and we had a lot of people very interested, and people who were taking that graphic with them. So it seems to be something that people are really interested in. So I'll make sure to send that information.
Absolutely. That's certainly something I believe we would be interested in sharing and spreading the word about as well.
Okay.
And forgive me, Vanessa, one more question before we move on to our friends at Medicaid. Are there any efforts to bolster the behavioral health workforce with a focus on providers who speak other languages, including Spanish, Somali, or et cetera?
So we do have, through our workforce, we have a whole team that's working on the workforce initiatives, and those are things that they are working through and working on to try to be helpful with that. I can get some more specific information from Zandaya, who's on our team and is working through all those details. I can get some more specific information on those initiatives from her, and happy to send that to you. But yes, that is definitely a part of the work that we are engaged in.
Excellent, Vanessa. Thank you so much again for your time. I would appreciate you would stick around to the end.
Sure.
Again, I think there'll be some teamwork and some of the answers that we'll require soon. So without further ado, we'll introduce our last speakers. We're excited to be joined by Stephen Alexander and Brooke O'Neill from the Department of Medicaid, who's going to share again their priorities and what might be ahead for the department. So Stephen and Brooke, take it away when you're ready. Thanks again for being here.
Yeah, thank you so much for having us. We're excited to come and talk to you guys a little bit about what to expect in the upcoming state budget. Brooke, you want to say anything to kick us off?
Well, no, we're just excited to be here today and share with you all the resources we have available.
Yeah, kind of to Lauren's point earlier, there is a lot of uncertainty and fun, as he put it, in the state budget process. So it is hard to predict exactly what all is going to happen. So I think we were going to, start with what we feel the most certain about going into next budget, and work our way back towards the things that we feel less sure about. I guess the things that we feel most confident that will be a big budget priority of us going forward is kind of just continuing and finishing a lot of the projects that we already have in motion. So the big one, obviously, is our implementing of our procurement of our new managed care plans, or we call it our next generation of Medicaid managed care. There are a lot of huge changes in how the managed care program is structured. To Lauren's point, like the vast majority of people, it is more than 90%, but I can't exactly remember how many, but most people are in managed care who are in Medicaid at this point.
And another thing that Lauren touched on was the multi-system youth. One of our big procurements was Ohio Rise, which is a managed care plan that is specifically targeted for those multi-system youth. We're serving, as Lauren said, about 8,000 children. It launched July 1st to make sure that those needs are being met within the community. So you have a community assessment in each of these kind of areas throughout the state that are best served, like boots on the ground, to make sure that they are giving those community-based services to the children that need them the most.
And so that's one of the major components of the next generation. Some of the other ones, in addition to just procuring our new managed care plans themselves, we were required to procure a single pharmacy benefit manager. So that is getting ready to launch later this year. We've been working on building our pharmacy provider network, and that's a huge departure from how we currently have our managed care structure in the pharmacy program, where each managed care plan goes out and procures their own pharmacy benefit manager. And the last several years have brought a lot of questions in terms of how those entities are operating and what is the appropriate level of oversight. So having oversight, transparency, just accountability has been a big focus. We still want to allow our managed care plans to be innovative, but we have come across a lot of situations where when we are faced with questions about alleged behavior or certain things are happening, we're not able to confirm or deny certain things, especially in the pharmacy program. So the single pharmacy benefit manager is a huge step towards having that level of oversight and confidence that the dollars are being spent as they're supposed to be. So that is getting ready to launch, and we can answer any questions if you have specifics about that piece of it. Another one in the vein of oversight is the fiscal intermediary, which sounds very technical and wonky, but it's a huge piece of the next generation that's going to bring a lot of additional transparency as well. We currently depend on our managed care plans for a lot of the encounter data that happens in the healthcare system. They send it to us often months later, where we find out, was a claim denied, was it paid? We don't actually see the claims themselves. So in the future, when a provider submits the claim, it's going to go directly to the fiscal intermediary. And then we, because we contract directly with them, will have the claims much sooner, and we'll have the actual original claims instead of having to track down information when there's a dispute between the provider and the plan. So it's going to add a lot of additional oversight. We're going to be able to react more quickly when there is a new issue that pops up. So if there's something happening that maybe we need to update our provider agreement, we're going to be able to find out what the issue is, what's going on much sooner, because we're going to have the data directly instead of getting it later. And that's also became very clear during the pandemic that we needed that, when a lot of elective procedures were put on hold, and we were getting asked by legislators and stakeholders, what are you seeing with the claims and the encounters? Has it dropped off? And we had to say, well, we'll tell you in a few months. So we're going to have that data much closer to real time once the fiscal intermediary goes live. And it'll also streamline some things for the providers who are submitting the claims, because it's going to standardize some of the functions of submitting the claims instead of having to learn a bunch of different ways that each managed care plan tailors their claim submission process. And then the other way that it streamlines some things for the providers is through a different component of our next generation called provider network module or centralized credentialing. Rather than having our providers sort of credential and show that they are in fact qualified to provide the care that they're going to be providing, with each managed care plan, different ways that each managed care plan has that process, we're going to be able to centralize that with Medicaid. A provider will submit their paperwork once with us. They'll get kind of a clean bill of health from the department that shows you are hereby able to go forward and be a Medicaid provider and contract with the managed care plans. That'll save them the time of having to repeat that process of proving their credentials with each successive managed care plan, and however they choose to have that process run.
Well, I was going to say, and I think all of these things combined are really the biggest part of the next gen, which is focusing on the individual. So making sure that our consumers and their individual needs are being met, and then also making sure that providers are being reimbursed correctly. And again, going back to the Ohio Rise program, that those providers are expanded to some of the community-based services and wraparound needs.
And while a lot of these things are fairly quick to explain, they require a tremendous amount of IT work and design work to be able to make sure all the systems are talking to each other and working as they should. And so going through the next budget, I think a big focus is going to be just having the ability to continue with that work, make sure everything is operating as it should. And then as we go live, there's probably going to be some retroactive work that we'll have to do for some providers and maybe looking at some claims if there's a lag in the claim submissions as we transition to these new systems. So there's going to be a lot of work for a little while yet to come to successfully onboard and complete the transition to the next generation. So that's going to be a big issue going forward. We also have a few other policy initiatives that we have talked about in past budgets that we haven't yet been able to implement, partially because of the pandemic that put a lot of things on hold. One example is expanding our state plan services for autism coverage, particularly ABA. Another big thing is continuing the work in our infant mortality provisions. And Brooke, you can maybe talk a little bit more in depth about that.
Yeah, absolutely. And to piggyback on some of the things Natasha focused on earlier, one of the things that we're doing are our infant mortality grant work in the OEI communities, which is the Ohio Equity Institute communities throughout the state. We actually added an additional one this year. So through a lot of that grant work that's been going on, we're discovering more evidence-based and evidence-informed community services that best benefit the mothers and children that we serve. So in addition to expanding the postpartum coverage, which I just wanted to add, also includes, like, you think of the OB services and the child care services that come after a pregnancy, but we're also treating the mental health needs and at-home care needs that some of these mothers and infants need to thrive, which has been really innovative and I think a service that's been well received. But with those grant work, it's informing us better on what we need for our mother and infant support program. So for example, lactation consulting, we now reimburse for, and we're looking at doulas and how we can incorporate them into to reimburse for those services and just trying to expand all of the opportunities that we have to help with the mortality rate in the state.
And so those are going to be some of the main focuses. And I think as we, look beyond that, that's where the questions start to come in the budget process, because in addition to just the limitation that all state agencies are going to have in what to put into their budget of just how much funds are available, there's another additional limitation that's unique to Medicaid that is imposed on us by the legislature called the JMOT growth rate. So there is a legislative committee solely dedicated to overseeing the Medicaid program, and they hire their own actuary, and their actuary provides an analysis to them that they then use to set a growth rate that we have to come in under when we submit our executive budget. So that hasn't been set yet. Their actuary is currently working on it, but wherever the committee votes to set the per member per month growth rate, we have to make sure our budget comes in underneath. So that is also going to impact how much we're able to invest in key areas. But it's important to remember that it doesn't limit what the legislature can add during the budget process. It only limits what we can propose in the as introduced version of the budget. So we know going into this budget, there are going to be a lot of requests for rate increases from providers. I know Lauren mentioned the inflation and Vanessa mentioned workforce issues. I mean, we are hearing that from almost all our providers right now, that workforce is a big issue, that retaining staff is a challenge. It was a key focus, I know, from a lot of COVID relief payments and ARPA relief payments that we've already made. So just, this is not a comprehensive list, but we know providers like dentists, behavioral health providers, skilled therapists, home and community-based service providers, nursing homes, transportation providers. Those are just ones I could come up with off the top of my head. Those providers will all be seeking a rate increase in the upcoming budget. And so our ability to contemplate that in our as introduced version is going to be impacted not just by our policy priorities and not just by the funds that we have available, but also by the JMOT growth rate. And then on top of that, we're going to be dealing with, a lot of people have talked about ARPA. And our piece of that, since I imagine it'll be a subject of at least one question, is the part of ARPA that was unique to Medicaid was the HCBS component. So the federal government, when they passed the bill, had a component of the bill to address HCBS capacity. So states would have a certain amount to be able to invest in having provider relief payments or addressing the increasing capacity or sustaining the capacity that we already have, addressing workforce challenges. And so that is a big piece of ARPA that impacts Medicaid specifically, and a lot of our other sister agencies too. So the way it's funded is a bit unique. Rather than just being a flat dollar amount, it's a percentage of the home and community-based dollars that we were already spending in a certain set period of time. So that money has been essentially earned already, and the amount has been determined. But it also, how far it'll stretch also depends on how we choose to spend it. Whether or not you spend it on certain things, you may or may not be able to get federal match on it. So that's why there's not a firm dollar amount that like, here's how much we have to spend. Of the amount that has been already appropriated, I think it was something around 560 some odd million dollars that have been appropriated through the General Assembly in House Bill 169 that were dedicated solely to provider relief payments. So there were additional provider relief dollars that went out that were non-ARPA, but the ARPA component did go to that purpose. And so we've sent that money out, but there is a lot of there are additional dollars that could still be appropriated. We know that's going to be a topic either in lame duck or in the upcoming budget on how to use the remaining HCBS component of the ARPA funds. And so we will, obviously be a willing partner to continue to engage stakeholders and talk to our sister agencies and the legislators on how best to use those dollars to address preserving and expanding our HCBS capacity. And then I guess the final piece that we know is going to be impacting our upcoming budget is going to be how things go with the public health emergency. Lauren already talked about that a little bit. A lot of you probably already know that when the pandemic hit, states received an additional 6.2% of the federal match. So they picked up a higher percentage of the cost of the total Medicaid program, which alleviated a lot of pressure on state general revenue funds. And our current budget was based on a certain assumption about when that would end based on the best information we had at the time. The pandemic has now stretched on longer than that. Public health emergency is still continuing. And so during this time, we can't disenroll individuals except for a few specific reasons. Once that ends, Lauren mentioned some of the requirements from the General Assembly to work through the individuals who haven't been renewed or redetermined in a while. And we're going to have to work with our county partners to do that as quickly as possible. We also have to make sure that we're following the federal guidance on how we can do that. So we're trying to kind of check all those boxes to make sure we're in compliance while supporting the counties as best we can, since they are primarily working through the eligibility side of things with Medicaid program. So I know someone mentioned the self-service portal. We have a big piece of that as well. And so we've been trying to make that as user-friendly. I believe it recently was made mobile compatible. So we're trying to do what we can to make sure that we're alleviating as much pressure off of the backs of our county partners who are going to have just a huge workload when the public health emergency ends. And then also just trying to prepare as best we can as we start to see caseloads maybe decline. And Brooke, was there something you want to add?
Yeah, I really want to follow up also with what Lauren said, that in addition to like making sure we have all the boxes checked, we want to make sure that we're communicating to all the stakeholders and to the community that is going to be most impacted by this unwinding. We are in development of a partner packet. We want to make sure that we maintain that continuity of message. I think there are a lot of different rumors, so to speak, I don't know a better word for it, out there circulating. So what our hope is, and there's a lot of CMS guidance attached to this, but we want to make sure that we're in alignment amongst those stakeholders so that we're clearly communicating to consumers, what to expect with this unwinding and redetermination. So hopefully we'll be able to get that out to folks here soon. And we just want to make sure that that continuity and messaging is aligned.
Yeah, I think since the public health emergency began, there have been, I think, at least 3 different times that the federal government has issued state health official letters and guidance on how the unwinding from the public health emergency was to be conducted. So amidst that changing information, we want to make sure that our members have the accurate and up-to-date information, and also the community partners. Brooke mentioned the partner packet. Like, we want to give this toolkit kind of to our community partners who we know will be interacting with the people who are enrolled in Medicaid, so that the best information is out there, accurate information is out there, and people don't have misinformation based on old data. So that's kind of what we're trying to do right now. And I think a big part of it is making sure that we're reaching out to individuals enrolled in Medicaid and have their correct address information, so that once the unwinding begins, people start to receive notices to complete the renewal process, that they're actually getting those. So we've been really trying hard to make sure that we have everybody's up-to-date information, so that we can minimize people who are disenrolled solely because they didn't get a notice. We want everyone who is eligible to be able to remain on the rolls and not have any kind of disruption in their care once the public health emergency ends. And then Lauren mentioned the third-party vendor. That's a component of House Bill 110 we were required to undertake. So we did obtain that third-party vendor who's standing by and ready to help us, and also like give the counties the information. I think the way we've operationalized it, or will be, is to kind of have a tier of folks that the vendor has identified to be likely ineligible, and the counties can begin and prioritize those applications and those renewals, so that they can kind of go through the process of right-sizing our caseload as quickly and as efficiently as possible. So that is the way we're going about complying with House Bill 110, but it certainly has been a challenge complying with not only the federal requirements, but also House Bill 110, but we're preparing to do that as well. So those are kinds of a lot of the dynamics that are going to be impacting our budget as it comes forward. And we're really looking forward to it. I would be among that small minority who calls the process fun too, but I know there aren't many of us. So with that, I guess if we have any questions, we're happy to answer them as best we can.
Excellent. Stephen and Brooke, thank you so much. A couple questions specifically for Medicaid, and then there are a number that I believe a couple departments and folks may want to answer jointly. We know that everyone works together very, very closely on a number of these programs. So specifically to Medicaid, switching gears back to the reprocurement, has the Department of Medicaid ever procured like this before? How does it compare to what other states are doing in Ohio's past Medicaid program? Seems like the state has been working on this for years and years.
It does take a longer time to do it when you make big changes. We could have done it a lot quicker if all we did was simply say we're going to keep the structure the same, and we're just going to put out an RFP for the new plans and see if we keep the same 5 that we currently have. It did take a lot longer because we were making a lot of these structural changes I mentioned, where we have better oversight. And obviously, if you're going to make those kinds of changes, it does add time because you have to make sure the IT infrastructure is there to where you actually have that level of oversight you aspire to have. And then,
and stakeholder engagement.
Yes.
We wanted to really get the information that we needed from our consumers and our stakeholders so that we could develop a program that was individually focused.
Yeah, the first part of that process was a request for information before we even got started with the program design, where we wanted to hear from people who use the system, providers and members directly and only, not anyone who would be applying. And we had several community meetings where we went to small towns. We went to meet with individuals who are enrolled in Medicaid and kind of a roundtable discussion. I think we did close to 20 of them to find out what's working, what's not. Do you like your plan? What are the challenges you have actually accessing the services that Medicaid covers? And I think that really informed a lot of how we then designed the program. But of course, that adds time. So that's one of the reasons I think it takes a long time. But a lot of the changes I think were based on that. I don't quite know off the top of my head how it compares with what other states are doing. We do think we're fairly unique in the single PBM design, but one of the states I know that we did draw a lot of inspiration from was Tennessee, who has kind of a similar model. But
and Ohio Rise is really unique.
Yeah.
As well.
Thank you so much. So it sounds like you got a lot of input from folks who use the system. I think and the next question pertains to providers. If they are excited about these changes, what kind of feedback, how did they engage kind of with putting together all of these changes?
I think one of the biggest pieces that they're excited about is the centralized credentialing. I know the director said that when she announced that our procurement was going to have that as a dedicated component, she said every provider group she spoke to got a standing ovation. So I'm not a provider, so I don't know the amount of paperwork that goes into credentialing with all of the managed care plans, but based on that reaction, it sounds like it's a lot of administrative work that hopefully will be streamlining for them. And it also ended up saving money because we don't have to pay the managed care plans to do that process duplicatively. So I think that's the piece that the providers are most excited about. But I think a lot of the overall structure they were mostly pleased with too.
Excellent. Thank you so much. Can you clarify what the JMOC growth rate is? Does this mean that it limits how many new members can join Medicaid?
No, it doesn't do that. What it does is it looks at the total spend of the program that's attributable to individual members, and it limits how much we can grow that per person. So if caseload goes up, that doesn't necessarily impact the JMOC growth rate directly. They might say the way it looks when it's voted on by the committee is, let's say they set it at 4%. What that does to us is we can't propose a budget that is more than like 4% per person more than what we're currently having in our baseline budget. So that if we have a higher caseload, that could be a total overall spend as long as it's less than like 4% growth per person. And certain things are excluded because they're not directly attributable to like the member experience, like administrative costs. But for the components of the Medicaid program that are directly related to patient care, which is the vast majority of it, that we do have to come in under that growth rate. But again, it's per person, and it doesn't limit the number of new people who can enroll.
That's really helpful, Stephen. Thank you. One more question just for you, and then we will open up to others. And I know that this will be different depending on the provider, but the question is, have Medicaid rates per providers been raised recently? Are there any overdue increases? I know that those are kind of implemental and incremental increases depending on the program, but if you can speak to any provider rate increases, maybe the most recent.
CBS.
Yeah, a lot of times those are contemplated in the budget. That is usually the time that we're mostly thinking about that. It happens other times, but for the most part, provider rate increases are done in the budget. And usually what we like to see happen is just make sure that the funding is there in our line item and we have the authority to adjust the rates. So in the last budget, I think what we were able to propose and still come in under the JMOC growth rate were very few rate increases that we had the space to do. Home and community-based services were really where we focused most of our proposed rate increases, and then additional providers I think got some rate increases along the way. And the budget before that, it was just transportation providers. I think was the only rate increase we were able to propose and come in under the JMOC growth rate. So there's not a dedicated time frame by which provider rates are automatically adjusted. It's sort of whenever the rule can be adjusted and the appropriation can be achieved during whatever bill is going through that calls for that. So, I mean, I mentioned dentists earlier. I think it's been a couple of decades since they saw a rate increase. For the home and community-based service providers, they've received single-digit rate increases in each of the last budgets. But prior to that, I don't think many of them had ever received a rate increase since those waivers had been around. So it really is just kind of a question of when the provider group can successfully advocate and acquire a rate increase. There's not a set interval by which we have to do that. Usually we're kind of monitoring our network adequacy for provider types. And when it reaches kind of a crisis point, that's usually when we have to do something. But unfortunately, it often has to get to that point before something is done because we have to stay within the appropriation that's been given to us.
Excellent. Steve, Brooke, thank you again for your answers and for being here. Sure, we will need you to jump in on a couple of the upcoming questions, but we will give you a chance to take a breath, maybe have a sip of coffee for a moment. So our next question is for Mindy with JFS. So one of the study committees that we've been watching that's been meeting over the summer has been the Childcare and Publicly Funded Childcare Step Up to Quality Committee. We know that they have a report due soon. So a couple of questions regarding that. When is that report expected to come out? How do you believe that might impact the upcoming budget? And then to speak to those ARPA dollars that you talked about for childcare. So specifically, how may they impact workforce and access for publicly funded seats? So a couple different parts of that question, and you can approach that however you think is best.
Yeah, and so you might have to remind me because I'll do my best to answer every piece of it, but if I miss something, please let me know. So the Step Up to Quality Committee, correct, has been going on for almost a year. The report is supposed to come out in December. The committee did not meet over the summer, and during July and August, they requested from the committee members to give their proposals for what they want to see in the committee report. September, they will meet again and they'll go over what those proposals are. I think two things came out, or two things that I can say from the committee, or what I think they're headed, is both committee chairmen made the commitment to not dismantle Step Up to Quality. So that I think is a plus. And then as far as where this will go with the budget, we're not sure. So it really depends on what the committee decides to focus on in their report, whether it is increasing PFCC to the 75th percentile, whether it's really looking at Step Up to Quality standards. We don't know. We will have a better idea come September where they will head with that. But right now we're just kind of watching as everyone else is to see where it's headed. And then the discretionary funding, what was the question around that?
Yes, will any of that ARPA funding be used to supplant the childcare workforce or increase access to seats?
So it cannot be used to supplant. So we already asked our federal partners for that. They said it couldn't be. So we will try to use some of it towards paying for PFCC, but not supplanting it. So what we know is when the market rate survey comes out, which it will before the budget, it always does, is it usually moves us up, right? And now that we know inflation is here, I'm sure we're going to see a jump in our market. So some of that discretionary funding will cover that market increase that we'll see due to the market rate survey. The rest of it, we are looking to see what makes the most sense and how we can help the childcare field and be strategic and intentional about how we use that funding. But I will say that the money has to be obligated by September. So the budget would be signed hopefully in July. So that really only leaves me 2 months to obligate millions of dollars. And I say that because I want people to understand what challenge that will be. We are already working on it internally, but we still have to do RFPs, we still have to do contracts, all of that will have to be done. So we really are going to have to be strategic and intentional.
Fantastic. Thank you so much, Mindy. Next question is heading to you, Vanessa. So you mentioned that the behavioral, and the governor has also stated that the behavioral health system was never fully built out in Ohio. How long will it take to get that fully developed? And has ARPA spending helped us catch up to realize a fully built out system?
So I will say it's hard to say how long it will take to fully build it out. I think it's going to be, I think, a number of years, but we are planning for that, as we work through the budget, as we work through, the priorities in our budget, and as we work through internal conversations, we are working through things, what can we do right now while building on to the system to continue that work into the future. So that one's a hard question I don't have an exact answer to, but it is one that we are being mindful of as we plan for the budget. And then as far as the ARPA funding, a lot of that I think has helped in the sense that it's provided funding to help, whether it's been through provider relief or whether it's been funding that has been, well, I will say the majority of our funds go out through an RFP competitive bid process. So it has opened up some opportunities for the department to provide funding for initiatives that maybe wouldn't ordinarily have been funded, just because there's just been a lot of extra funds. And so it's been an opportunity to fund some, and it's not even necessarily just the ARPA funds. It would also, I think, include all the federal money, even including the SOR grant. Because I'm thinking the thing that comes to mind for me is just even with the SOR 2.0 grant, there was a section that was allocated, or there was an RFP posted, but there was a certain amount that was meant to be allocated for innovative type programs. And so I think, those are also things that are helping to fill that, as, we're able to work through those kinds of opportunities and collect data, and then figure out what's working and use that as the guidance to, decide what to expand and how to expand things based on what's working.
Vanessa, thank you so much. So again, rapid fire questions. Stephen, Brooke, and Vanessa, if you want to keep your ears open for this one. Shifting over to Ohio Rise. Wanted to ask both of you, how does the Ohio Rise launch impact your budget asks? And is there any discussions happening around access to behavioral health care for those who are just above the income eligibility for Ohio Rise, but still considered low income, kind of that gap right before exact eligibility? So whoever would like to go first, please jump in.
So I can jump in. So for how it'll impact the budget ask, I think it'll certainly, our budget's going to include just maintaining Ohio Rise. One thing that should be hopefully a little easier this time is because since we were proposing launching a new program in the last budget, you really have to call that out, because it's sort of a departure from the baseline in a way. Whereas now, having launched Ohio Rise, we'll be able to kind of bake it into the baseline. And so, there won't be like a big jump in the chart that you then have to explain in the budget. So we'll certainly propose, I think, maintaining Ohio Rise, and that'll impact the budget that way, since it does call for a lot of services we previously didn't cover. But because we've already launched the program, I think it'll just sort of be baked into our baseline budget. And then, Vanessa, I'll let you go ahead, and then Kelsey, you can repeat the other part of the question.
Certainly.
So I will say, I'm sorry, go ahead.
Just talking about eligibility for those who just missed the mark in terms of income levels to be eligible for Ohio Rise.
So I will just jump in and say, and this doesn't, it maybe will help answer this question. It doesn't fully answer it, but at least it maybe will help inform the work that's being done. So even though, Medicaid is implementing Ohio Rise, one thing that we are doing, that OMAS is doing in partnership with the Department of Medicaid, but with all of the other agencies that are impacted by the multi-system youth population and by Ohio Rise. We have Department of Health, Job and Family Services, Developmental Disabilities, Department of Youth Services. So it's a partnership between all agencies, but OMAS is the leading this piece of the initiative, and it's a center of excellence for the child and it's CABH, child and I think it's the child and adolescent behavioral health, but it's a center of excellence. And so we have gone to controlling board several times since the contract was first awarded to Case Western University. And so what the goals of that are, it's to help provide, to help do some research, to help provide information, training, best practices, to help provide that for providers and also people that are needing those services. It was to there's also goals in there to help. There was a recent controlling board request where it was, funding that was going through to help providers who are going to start providing these or offering these new services. And it was to give them funding to help them either expand or if it's a new provider, it was and those are all will be distributed competitively. But so there's a lot of work that's going on too through that center of excellence. And I know that, the children who are, not necessarily Medicaid eligible, or for families that are not necessarily Medicaid eligible, but there are discussions, and that, those things are being reviewed and researched through the COE. So it is something that is top of mind there, and will inform our budget requests.
And on the question about individuals who are just above the Medicaid eligibility threshold, it's a really challenging thing for us to address, because you're kind of saying, how can Medicaid help individuals who aren't on Medicaid? And so it's a little bit of a challenge, since we're predominantly federally funded. You know, without just flat out raising the eligibility, there's not much we can do, since it's just by definition beyond the scope of our program. I know there are a lot of legislators who have had conversations over the past couple of years about addressing what they term the benefit cliff, which is that noble goal of just like, hey, there's this threshold, and once you go like an iota over it, you're cut off from a lot of things. And it's a really worthwhile goal. It's just a challenging thing for Medicaid directly to address, because we're sort of by definition kind of confined, since we're predominantly using this federal money that's is north of 60%. And in the group 8 population, it's 90% federally funded. So anytime you want to go beyond that threshold, you either have to use state-only funding, or you need to seek some kind of demonstration waiver, or just flat out raise the eligibility threshold. So that's a challenge, I think, from a Medicaid perspective to address. But you know, perhaps with Ohio Rise having that multi-agency component, it's going to maybe be able to address things like where a different agency takes the lead using state-only funds, and we can hopefully kind of braid everything together in a way that seems seamless to the actual user, so they don't have to go, oh, well, it's over this % federal poverty level, so I don't go to this agency, I go to this agency. And one of the benefits of having Ohio Rise from a structural standpoint is you can kind of have a lot of agencies work together in a way that appears like a harmonious single program to the people who actually need any of the programs that are involved behind the scenes. So I think long-term, as we think about where we can go next on Ohio Rise, that's a way that we can maybe just provide services that doesn't appear so siloed to the people who actually need them.
Excellent, thank you. And what a fantastic explanation. Thank you so much. So Mindy, this next question is for you. So your mention of the upcoming market rate survey sparked some questions in the chat. Could you just expound a little bit about what that is and how it informs decisions by the department in terms of reimbursement rates and how that childcare workforce is supported?
Yeah, so every 2 years we are required, well, it's not every 2 years. I think it's actually every 4. We do it every 2. Every 2 years, the state is required federally to do a market rate survey. And essentially what it does is it goes around the state of Ohio, and we have a third-party vendor, and they determine what the going rate for childcare is in different areas within the state. We have different categories of pay that we pay for PFCC children, which is our publicly funded childcare program. And the market rate will tell us where we are, like what percentage. So right now, we're at the 25th percentile for paying for PFCC and that's without the step up to quality enhancements. So if you are getting a step up to quality enhancement, it increases what we pay, but we pay at the 25th percentile. The market rate will increase those pay, like every 2 years we look at it to determine what, how much increase the market has seen, and then we adjust it so that we are paying at the 25th percentile. We in Ohio do it on the budget cycle, so we will get our results for that market rate in October, December at the latest, to help inform what we ask for in the budget.
Excellent. Thanks so much, Mindy. And this last question that we have with you can go to anyone. So our last budget training, we were very grateful to have the assistant OBM director with us on the same day. Budget guidance came out for the upcoming biennium. She mentioned that there's a focus on results-based budgeting for the upcoming biennium. How does that change how you approach the budget or your expectations?
I can speak from the JFS perspective. So we are very data driven. So anything that we are doing will have data to support our requests. So if we're requesting additional funding, we'll have the data behind it to show that we need it because we need X. Additionally, we will look at how we are distributing funding and whether or not there should be a component around giving funding for reaching certain benchmarks or metrics when it comes to the counties or whether it comes to childcare. So we know that this legislature is very data driven and this governor is very data driven. So we are trying to utilize the data to help us make decisions and to request funding and to figure out how to keep funding moving forward.
From a Medicaid standpoint, it's pretty similar. You know, a lot of our budget initiatives are going to be focused on, you know, probably provider rates or, you know, what services are covered. And so when you think about what types of performance measures you can tie to those, when it comes to provider rates, you're probably looking at network access and network adequacy. So there's usually something we can point to there where we can say, hey, there's maybe a time and distance standard, or perhaps there's a gap between the time that services are authorized and are actually provided that we can kind of focus on. So those are a couple of ideas when we look at things like, you know, provider rates that we can sort of look at. Hey, we want to improve access to this type of service. When it comes to some other initiatives, when it's tied to something like health outcomes, it becomes more challenging because there's so many variables involved. So what we tend to do is we have data behind like why we want to make the investment. Like we know that if we do X, it'll yield better health outcomes, and we can usually cite a study or something like that. It's difficult to look back and say, we got these better health outcomes because of this policy change, because it could have potentially been explained by something else that happened. You know, what was your overall caseload, or perhaps something else just impacted the data. So it's data driven usually on the front end, but sometimes those things are hard to prove after the fact. Like because we did X, emergency department utilization went down, for example. Well, emergency department utilization could have just gone down because people just weren't as sick. You know, there could be other factors affecting acuity of the members that are enrolled in Medicaid. So that can be a challenge to account for all those variables, but as much as we can, we already try to make data-driven decisions. So I think the budget guidance didn't impact us too much, other than we're probably just going to emphasize that a little bit more when we communicate with OBM.
And I would say pretty much the same as what Stephen and Mindy said. I think it'll be helpful in terms of, you know, when we are working through our budget requests and looking at those initiatives, we'll be able to, you know, to tie that to certain outcomes. I think that'll be helpful as we, you know, talk about things in the future, and we'll be able to help tie that back. I think we're going to run into similar challenges as what, you know, Stephen said in some certain instances, but I think, you know, as a whole, I think it'll be something that is actually really beneficial, you know, and will help, you know, honestly, I think it might help us as we move through the budget process. It might help us on the front end to be thinking of the things and putting it on paper, the things that we end up getting asked during the budget process anyway, that, you know, legislators ask and want information on. And so we'll already have that documented ahead of time too. So I think it'll be a beneficial exercise, that I'm sure there are certain kinks that we'll have to work through, as every agency does, but I think overall it'll be a good thing.
Thank you so much, everyone, for being here. Vanessa, Brooke, Stephen, and Mindy, we want to thank you so much for your time, for being so generous with your time today. We know that's a lot to ask, and you are very, very busy, again, thinking about the next budget proposal. We know those are due coming up in a few months, but wanted to, once again, thanks for being here. There was a number of questions that we did not get a chance to address in our time today. We'll certainly put those together and send to our panelists for them to answer, and then we will certainly provide them up on our website. As you can see here on the screen, this is a series. We hope that you will join us in our next installment of our Budget Training Academy coming up on September 21st at the same time, 10:30. We are excited to invite a number of Advocates for Ohio's Future member organizations to talk about some different health and human service sectors, I would say, and how we all work together again within the budget process, and to find our priorities and really what major issues we are going to push again, beginning in that General Assembly through the budget as well as for the next 2 years. As always, our recording and slides will be sent out and will be available on our website that is on the screen. You can also register for upcoming sessions. We thank you, and we of course thank our partners at the Center for Community Solutions. Lauren and Natasha, thank you for being with us as well. We will see you next time. Hope you have a great rest of the day, and we will see you soon. Thanks again, everyone.
Thank you.
Thank you.